for me to speak at Ho Chi Minh finally. It's my first time to visit, and I'm so glad that I make a speech here. Okay, I wrote my articles and books. Actually, I'm not a professor. I just work in my own clinic. But I like to write down the articles with Dr. Kim also, of course. The reason is that we have to perform the procedure by scientific evidence. Like 10 years ago, we just did injection techniques or any other skills, but usually they are not belong to associated with the scientific evidence. But right now, in these days, we usually have to perform by the scientific evidence. Otherwise, that's Western doctors or other doctors just don't understand, don't agree what they are doing. If I do filler injections such as like this, and other doctors always say that why, and they just always ask me about the scientific evidence. So that's why I like to write a lot of articles. And today I'm gonna talk about these articles. So whenever I make a presentation, I make a presentation about filler anatomy or filler choice, what kind of fillers I'm gonna use, and as I told you, how to inject or complications. Today I'm gonna talk about some complications about these delayed inflammatory reactions and also vascular complications, because one of the most important thing is vascular complications. Whenever you perform the filler injection, you have to think about non-vascular complications or vascular complications. That is most important. So I'm going to talk about non-vascular complication a little bit, and then vascular complications. So this is in this book, in filler complications, and this is, we call it delayed hypersensitivity reactions. After injecting the HA fillers, a few weeks or a few months later, the patients come to clinic because of swelling. That we call delayed inflammatory reaction or delayed hypersensitivity reactions. This is because of COVID-19. A lot of this occurred because of COVID-19, such as this case, delayed hypersensitivity reaction to HA fillers post-COVID viral infections. And 32 female, and then she got fillers, and then she got the COVID infections, and then the swelling. Another case is that she got the restaurant before, and then she got the vaccine, and then she got the swelling. That we call it delayed inflammatory reactions. Another case is 31 female, and after she got the Moderna vaccine, she got the swelling. So, why? We have to think about why this is happening. So, this is just a theory, but because I didn't do the clinical experiments, but this you can see the article on free articles, because it is open access, and this might be the cause of delayed inflammatory reaction. I wrote it, so if you are interested, you can write it. You can see the articles. So in this article, that you have to think about how filler is made. Well, there is a little bit difference between the company, of course, but usually it's like this, and you have to think about this process so that if this process is wrong, then it might have a problem with the filler complications. So that's why we put the HA powders, we dissolve in alkali, and then we mix with BDD, and so on, so on, so on. And finally, autoclave. So, why do you have to know this process? Is because of this thing. This thing is, we call it cross-linker. Usually, we use BDDE, right? So, HA is components of your body, right? HA is, and it is degraded by the hyaluronidase every time. But this is cross-linker, and with the well cross-linked BDD, then the filler goes more like a 6 months, 1 year, or something like that, right? So we always have to think about this BDD, but the reality is not all the BDD is cross-linked, but we have pendant type BDD, free type BDD, and this non-cross-linked BDD. So this kind of thing is impurities, right? This can cause delayed inflammatory reaction. That's my theory. So because that I investigated these things, and it has a lots of this kind of BDD, and this kind of BDD, lots of filler has this one. So this is very important thing, and you always have to think about that HA filler is not all the clean thing. So the most important thing is that you have to use the most clean HA filler to your patients, to your daughters, right? You can't use anything to your wife because she's living with me. If she has a complication, I can give a medicine to her. But actually, that you have to use the most clean HA filler to your daughter or to your patients. So that's the important thing. So this is the example of not good filler. HA filler has a pendant stability. It's not cross-linked. HA should be cross-linked to each other, but it's not. This is impurities, right? This is well cross-linked. So what I mean is that you have to have a well cross-linked BDD and also the low portion of pendant type BDD. So this kind of fillers, I'm not gonna use this one. So the final thing is that HA filler itself can have lots of pendant type BDD. So that's the most important thing. And the second thing is that you can have impurities such as silicone and so on. So what I want to tell you is that there's so many HA fillers in this aesthetic field in Korea also. And the most important thing is that you have to use good product. That's very important. Not many doctors are saying this kind of things. So if you are interested, once again, you can read these articles. And second complication, as I told you that we have to think about non-vascular complications and vascular complications, right? So vascular complication, you have to think about first skin necrosis, which is maybe arterial occlusions or venous occlusions and skin necrosis, and the most serious problem, ocular complications. So I will start from the skin necrosis first. So you have to understand these arteries. Of course, that's a basic thing, right? Basic. Supratrochlear, supraorbital, dorsal-lateral arteries. That's most important arteries. And of course, facial arteries, frontal branch of temporal arteries. That's basic, right? So this is how we treat when the artery is mixed by the HA fillers, and we do the repetitive subcutaneous injections for dissolving. So this is an article that we can have such as we inject HA fillers at nasal level 4 and then other problems. Or 3 days after we can have such as problems and so on. So the one of the most important thing is we have to inject hyaluronidase 1 or 2 days. So what we have to do is that you always have to tell to the patients to come back 1 day after or 2 days after. Or if patients is very busy, then they could take up photos and send to clinics, right? So you always have to check it because patients doesn't know these things. Patients think that she is just gallops or bruising, right? But if the time goes too far away, then it's not reversible. So you always have to check the complications. That's another case of nasal level 4. That's another case of nose. This is not my case, of course. It's written in articles, but the one of the most important thing is that you have to inject hyaluronidase as soon as possible. To prevent the article, I'm using Doppler ultrasound. Actually, Dr. Kim gave me advice to buy the ultrasound was it 8 or 9 years ago, something like that. He asked me to use this one, so I bought it, ultrasound, and I cannot see anything. At first time, I wanted to kill you because I bought the machine without my wife's permission. And I cannot see anything. And I always talked to him, called him how to use. But right now, I have to use it because I can detect where the artery is. For example, if you want to do the nasal level form augmentation, you detect it, and then there's a facial artery, and then you have to detour it and inject. That is much safer. The only safe method until now. So with Dr. Kim, we wrote a lot of articles about the Doppler ultrasound, such as if you want to inject the globular area, then you have to detect the supratrochlear arteries, or that if you are something like that. So we're gonna see from the first one, forehead augmentation thing. This is it's not my video. It's in the PRS. That you can see the supratrochlear artery and supraorbital arteries in cadaver dissection. So that's supratrochlear arteries, very important arteries. If you inject fillers in there, you can have a blindness. Also, if you have injected to supraorbital artery, then you might have a blindness. So it's very thin arteries, but you always have to think about this problem before you inject to correct the globular wrinkle or the forehead augmentations. So we gonna see we saw the cadaver anatomy, and if we detect the Doppler ultrasound to the glabellar area, then you can see the supratrochlear arteries, supraorbital arteries, and so on. So if you want to correct before that, you can see the supratrochlear arteries there, right? Well, blue is not vein. It's a direction, so sometimes the artery can be seen as a blue, or sometimes it can be seen by the red. So anyway, that's you have to detect the supratrochlear arteries, and then if you want to inject the HA filler, you detour it, not inject the arteries, right? That is very, very important. This is patients that I just took a few days ago because of elastic filler. Then you can see the supratrochlear arteries there, very, very thick one, is going to entering the ophthalmic arteries. So if you inject some fillers here, then you might have a couple problems, right? So after detecting HA filler, after detecting Doppler ultrasound, I am injecting forehead augmentation for elastic filler, and the puncture and forehead HA fillers, and then I'm using 21 gauge of cannula to perform the HA fillers injection. Of course, that you already saw the supratrochlear arteries running pathway, which is deep or the superficial. So I'm using as a vascular mapping, we call it, and then we inject little by little by the detouring the artery. That is very, very important. And finally, I always make an upright position, because it's very different to inject to supine position to upright position. So I inject at first time for the supine position, and then finally I make inject to upright position. It's an upright position, and then I'm injecting the HA fillers, elective, to the forehead areas, little by little. That is, for me, I think it's one of the most safe method for until now can inject forehead augmentation. And second, you're gonna see the temple area by the cadaver anatomy. It's temporal area is a very multi-layered structure, which is muscle, and then we get the deep temporal fascia and superficial temporal fascia, and we can see the frontal branch of superficial temporal arteries there, and also you can detect deep temporal artery. So sometimes some Western doctor just try to inject directly to the 1 centimeter to the eyebrow to the upper area, but sometimes you can detect deep temporal arteries there. So it is not safe method for me. The most like just a direct inject to such as like that is quite a dangerous thing. So what we do is that we do the Doppler ultrasound also to detect frontal branch of superficial temporal arteries. As Dr. Kim already mentioned about this, sometimes superficial temporal artery runs to the in front of hairline or the inside the hairline. So you can see that the superficial temporal fascia is there, and then you can detect the frontal branch of superficial temporal arteries running inside the superficial temporal fascias. So if you inject the fillers in there, that's very disaster, right? So that's you have to understand it. So what we are talking is that we always have to think about frontal branch of superficial temporal arteries running like that, and we also have to think about deep temporal arteries. So before we inject to temporal area, she's gonna we can see the superficial temporal arteries there. And also, this is very, very important. As I told you, if you inject directly to the needle to temporal area, then you can have the deep temporal arteries embolism. That's very, very important, actually. And it can cause blindness. There is a case report of that injection. So for me, we usually inject HA filler to the between superficial temporal fascia and the deep temporal fascia. Third place is nose area. And the cadaver, you can see that those are lateral arteries running through the facial arteries running to angular artery, and then it can cross the nose. So midline injection is not 100% thing. So this is another article for us. You can see that facial arteries running. Then you can see the midline. Those are lateral arteries running, and then if you inject there, then it might be a problem. So if you see that those are lateral artery, you can see some arteries there. It's a little bit lateral to midline, but anyway, that's you can see, you can detect that. So this is another case of we injected a few days ago because of elastic fillers. You can see that those are lots of arteries there. So you just have to detour the artery and then you inject little by little. I'm going to tell you, a lot of doctors like to use infralobular approach by cannula or something like that. But I'm going to tell you later why I'm not using that thing, that infralobular approach, because it's the most common procedure of the ocular complications. But I'm going to tell you later about it. The fourth place is the nasal level fold corrections. Of course, you will know that this facial artery is running to the nasal level fold area. So it is quite very, very dangerous place. But a lot of doctors says that to inject to, and if you touch a bone, then it will be safe. But if you see the Doppler ultrasound, it's not 100% safe. Of course, you can see the facial arteries running to subcutaneous layers. So you have to understand the pathway of the facial arteries. So if you can see these subcutaneous layers, you are running facial arteries running to the nasal level fold area. So when you inject there, it is not 100% to inject to the supraperiosteal layers. So though, actually, Dr. Kim and I always say about this thing, well, it is okay because that we feel comfortable after detecting the artery. We feel much safer. So I'm using it these days. Of course, that she can also facial arteries can be detected, right? That's to the nasal level fold area, right? And she's fullness because she wanted to. Well, actually, I'm not gonna to detect all the places for the Doppler ultrasound. For Doppler ultrasound, I usually use the supratrochlear arteries and also facial arteries, but she really wants to do the pretarsal fullness. Okay, the third thing, very, very important, is ocular complications. This is just accepted, unpublished article. This is just accepted to plastic and reconstructive surgery, and I investigated the 2000 from 2000 to 2025, and there was 232 patients with ocular complications, and then I did a meta-analysis. And visual recovery rate was only 27%. And the most important place is nose. So nose injection is very, very dangerous. So the mechanism of the ocular complications, a lot of doctors already know that. If you inject the supraocular artery, supraorbital, the filler goes back to the ophthalmic artery, and then ophthalmic artery the filler can go back to the central retinal arteries and blindness. That's perfect. So in Korea, one or two cases was asked me for advice. That's first case. 22 female patients. She got the forehead augmentations, and she transferred to general hospital. And the doctor called me for advice, and she was transferred to general hospital, big hospital, and what treatment was performed at big hospital was nothing at all. Couldn't do anything because ophthalmologist doesn't care about the treatment. They don't know how to treat. So and nothing was performed, and the patients was transferred to Yonsei University, and the treatment was performed, nothing at all. So if you inject HA fillers, such as nose augmentation, and the patient says that she got blindness and she cannot see anything, then the doctors would be panic. Patients also panic, right? So we always have to think about this protocol. This protocol is very, very important. I think it's one of the most important things before you perform the filler injection. Of course, if you want to not to have complications, ocular complications, there's only one solution: not to do it, right? That if you don't use HA filler, then it's 100% safe. But if you going to inject HA filler to the patients, you 100% you always have to know these things. You always have to think about these things. If patient says not blind, what are you gonna do? What are you gonna do to her? That is most important thing. Because if you transfer to the big hospital, they don't know how to do it. They don't care. And of course, so the final diagnosis was branch retinal occlusion, and the visual acuity was 0.7, and permanent visual field defect. Second case was held last year. The patient was forehead augmentation also. She was performed 23 gauge 5 centimeter cannula. So what cannula are you using in your field? What cannula? For me, I'm using 21 gauge. 19 gauge is 0.99 millimeters. So that is 19 gauge is same as supratrochlear artery diameter. So smaller than 19 gauge, such as 21 gauge, 23 gauge, 25 gauge, is very thin. You can perforate artery. So that is not safe. You know, some doctors always says that cannula is safe, but it's not. So whenever you use a cannula, you have to use a big cannula and very, very slowly. You know? So she has used the 23 gauge of 5 centimeter cannula to Helen approach like this. And there was no pain. Just after feeling injection, left outlet pain occurred. And then she said that there's a visual field defect there, this area. And the hyaluronidase was injected nearby. 14 vials was injected. Left visual field was still and transferred to eye center. The final diagnosis was some ciliary retinal artery occlusion and no treatment. And 6 p.m. asked me, and there was I told the doctor to go to the big hospital because I'm gonna connect to perform the IATT, but there was a medical problem in Korea by that time. There was a big issue. All the emergency was at strike, so we couldn't do anything. The patients was performed the high O2 chamber at 7 o'clock, and 12 o'clock, PM 12 o'clock, she was performed the retrievable hyaluronidase. And the final thing is, final was yes, partial occlusion, and then IATT was refused, and then she got the partial occlusion blindness, visual field defect. So, suggestive treatment for the ocular complication is you can have Ocamasa, Timolol, or any other things, or hyperbaric oxygen. My clinic has a hyperbaric oxygen, but it's just a supportive treatment. It's not the definite treatment, right? So, I'm gonna tell you, maybe there is a treatment here. Maybe there's some treatments of, but definite treatments, but we are not sure until now. Until now, no doctors in the world is saying that this is the definite treatment. So I'm going to tell you about the suggestive treatments until now. The first one is that supraorbital notch injection, which is the same as HA filler injected blindness. You inject to the hyaluronidase here, and the hyaluronidase can go to there, and there might be some hyaluronidase can go to there, but for me, I don't think it will work, but it's suggestive. So suggestive thing is that this is how we some doctor says that it is a suggestive treatment, which is a supraorbital notch injection of hyaluronidase. But anyway, you can see the videos.
Ai quay cái video có tầm như vậy? Quay từ thôi luôn đó.
If this works, then I will perform it. Oh, I don't know. And the second thing is that the retrievable hyaluronidase. Retrievable hyaluronidase is suggested by a few doctors, including Steve Fagan. And this is the first case that was written in 2017 in Dr. surgery, and is a restoration was performed. And we can see how they do the retrievable hyaluronidase injections. By the supine position, they inject to the glove, and then inject very high dose of hyaluronidase. That's how we perform. And I wrote in the 2019 the rabbit experiment myself, and it is written in the plastic and reconstructive surgery. So I think this is working actually, because I also did the rabbit experiments. And the third suggestive treatment is IV hyaluronate injection, but I don't know. There is no experiment. It's just a suggestive, right? And the fourth thing, this is I think this is the game changer actually. We call it IATT, intra-arterial thrombolytic therapy. It is written in the Chinese paper, and then this was performed IATT. They says that recanalized, but the visual restoration has a limitation. So IATT is I think this is one of the most important things, because another paper from the China in 2020 has she got the blindness. Non-light precision can restore it. Light precision was restored. So there are so many cases of restorations of IATT. So we did a rabbit experiment. This is I did myself. For the rabbit experiment, this is rabbit. This is Bhutan Seoul National University, and then we are performing IATT. We inject canalizations from the femoral artery goes to the abdominal artery, go back to the to internal carotid artery. There, and there's a rabbit. There's a rabbit mouse there. And if we perform the angiography, just like that, and we can see all the angiographies and arteries there, right? So you inject HA filler to make a blindness. So you inject HA filler, and then you can have a blindness in those areas. And then if you inject hyaluronidase, then you can have restorations, and we can perform the restoration of visual field. But it's not definitive. So I want you to know that this suggestive treatment, I want to do the systematic review and meta-analysis. So we did, as I told you before, we did a test, gathered a lot of articles, and this is the articles. This is all the articles until now, and nose is the most danger zone. So many blindness cases of nose. Of course, glabella and forehead also, but there's so many nose cases. So that's why I'm saying that nose injection to infralobular approach, especially those doctors who think that cannula is very safe, can have a lot of blindness cases, such as 23 gauge is not safe. Okay, so a lot of doctors saying that if I inject a cannula by using cannula 23 gauge, it is quite, but it's not safe. There's so many cases. And as I told you, that filler can go back to the ophthalmic artery and then goes back to central artery. And one of the most important thing is that where the filler is injected. So what I mean is a partial thing, such as PCAO or the PION or BRAO, is better to have restorations. But the OAO and CRAO is very, very bad prognosis. So you always have to think about how this works. And as I told you, that BRAO and PCAO has 85% of restoration, but the OAO and CRAO is not. And the initial thing is that non-light perception has 21% of restorations. But if it's non-light perception, such as light perception also, and then we have 51.7% of the restoration. Actually, time was not very important. I thought that the time is one of the most important for treatment. Time, yes, because that we learned from that the visual restoration is 89 minutes because of the monkey experiment. But sometimes like 144 hours later, if they perform the IATT, there was recovery. I don't know. It's but the result was such as like that. So time was not very important, and we performed the meta-analysis, and the proportion was such as that. This confidence interval was such as like that. And as I told you, cannula-induced ocular complication 165%. Needle-assisted is 35%. So cannula is not 100% safe. And second thing was that there was asymptomatic infarction because patients is pain of the ocular complications, right? And then she says that I cannot see anything or something like that. But in fact, there is so many infarctions accompanying. So we always have to check that cerebral infarction also. And as I told you, that initial visual acuity is very important. So it's my recommendations for until now, because the filler complication book was written in 2019, and I wrote almost every year of new things, developing advanced techniques of. So this is until now recommendation. Contact 911, and then if pupil reflex, and then I will perform the retrobulbar and then I will transfer to in Korea. I will transfer to Bundan Hospital, and then there will be I'll call to my professor for IATT, and then we will perform the IATT. Okay, thank you very much.
Vâng, xin được trân trọng cảm ơn bác sĩ Lee Won. 이분 원장님의 훌륭한 발표에 감사드립니다. Vâng ạ, và tiếp theo chương trình thì chúng ta sẽ đến với phần trao đổi ngày hôm nay, thảo luận ngày hôm nay dưới sự dẫn dắt của phó giáo sư tiến sĩ bác sĩ Lê Thái Lân Thanh, và chúng tôi xin phép được mời các cái diễn giả và chúng ta có những bài phát biểu trong buổi chiều ngày hôm nay bước lên sân khấu ạ. 네, 이제 레타이먼타이 과장님과 오늘 오후 토론 세스는 시작하겠습니다. 오늘 오후에 그 세 분 연자분을 무대로 모시겠습니다.
Quả là các bài báo cáo rất chất lượng và thú vị. Có lẽ là những vấn đề mà liên quan đến làm đẹp đã hấp dẫn rồi, thì những vấn đề mà liên quan đến học thuật để giải quyết những biến chứng của các kỹ thuật làm đẹp, đặc biệt là filler, thì chúng ta thấy càng bị thu hút nhiều hơn nữa. Thật sự thông tin cũng khá là bất ngờ và vỡ bà, đó là chúng ta lại được trao đổi thông tin với lại tiến sĩ Lee Won, là một trong những tác giả mà cái sách mà chắc có lẽ là các bạn đều, nếu như có thực hành về tiên chất định đầy, là đều cũng đã có ít nhất một lần ghé mắt tới để đọc một số cái thông tin trong đó. Cảm ơn bác giáo viên đã đem đến cho chúng tôi những cái giải thích và gặp được người thật việc thật rất là thú vị. Thì không biết là trong hội trường của chúng ta hôm nay đến giờ phút này, quý đồng nghiệp có đặt những câu hỏi hay là những phần tham luận gì hay không ạ? Tôi thấy rất là ngạc nhiên, bởi vì mà số lượng báo cáo mất thị lực là cho đến 240 mấy ca tại Hàn Quốc vào những năm gần đây. Thì cái tổng cái số lượng thì tôi thấy là trên slide tiến sĩ Lưu Quân nói rằng là unpublished, có nghĩa là chưa có được công bố. Như vậy thì có thể nếu mà điều tra xác thực hơn thì con số này có thể tăng nhiều hơn. Và tại Việt Nam thì cũng tương tự, số lượng của chúng tôi cũng chưa được công bố, tuy nhiên là cũng khá chứ không phải là hiếm. Và dĩ nhiên là phải thấp hơn con số mà tiến sĩ Lưu Quân có trình bày trên slide rất là nhiều. Tuy nhiên trong cái lĩnh vực mà tiên chất định đầy, chắc chúng ta không ai mong muốn, cũng như là tâm trạng tâm lý của những bác sĩ mới bắt đầu làm việc, bước vào cái danh mục kỹ thuật tiên chất định đầy thì rất là dễ có một cái tâm trạng căng thẳng, lo lắng trong khi thực hiện, cũng như là sau khi thực hiện. Nếu như mà nhận được cuộc điện thoại của cái khách hàng mà mình vừa tiêm chất làm đầy ở những cái vùng nguy hiểm mà chúng ta cũng vừa được nghe trình bày, như là trán, mũi, thái dương, gốc, ở động mạch môi trên, môi dưới, cũng như là những cái vùng ví dụ như là nó có thể đi vòng, nó có thể có những cái thông nói bàn hệ từ động mạch cầm á, thì nó vẫn có những thông nói bàn hệ với động mạch dưới hậu mắt, vân vân. Như vậy thì hầu hết chúng ta thấy không có cái vị trí nào trên mặt mà có thể chúng ta được lơ là hay xem thường khi mà chúng ta thực hiện kỹ thuật này. Chỉ có riêng cái vùng mặt giữa đó, mà ở vùng má bên thì một chút xíu thôi, có nghĩa là nó có vẻ an toàn hơn ở những vùng khác. Và hiện nay với hướng dẫn của siêu âm cầm tay thì có thể là, cũng như là báo cáo viên đã nói, tôi mua về lúc đầu tôi cũng biết để làm gì, rồi sau đó tôi cứ hỏi từng lần một, và sau cùng hiện nay là thấy là cũng thiết thực để có thể sử dụng. Thì không phải chúng ta vừa sử dụng vừa siêu âm vừa tiêm chất làm đầy, mà chúng ta có thể là siêu âm trước để xem biến thể về hệ động mạch, đặc biệt là hệ động mạch trên mặt của người bệnh đó, của cá nhân đó, hoặc là động mạch tại cái vùng mà chúng ta muốn tiêm nó như thế nào. Nếu mà quý đồng nghiệp có tham dự những cái lớp đào tạo cấp chứng chỉ tiêm chất làm đầy trong thẩm mỹ da của khoa gia liễu thẩm mỹ da bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh phối hợp với lại trung tâm đào tạo nhân lực y tế theo nhu cầu xã hội, thì quý đồng nghiệp cũng đã biết là khi chúng ta phẫu tích là cái hệ động mạch ở trên mặt quả là nó rất là thay đổi mà chúng ta không ngờ và khôn lường. Cho nên là cái sơn cầm tay lúc đầu thì cái tâm lý của tôi cũng có vẻ là không ủng hộ lắm, bởi vì tôi nói nếu mà vừa siêu âm vừa tiêm thì chắc chắn rằng chúng ta sẽ không control được cái thao tác, cũng như là giữ cố định được cái đầu của cannula hoặc là kim tại vị trí mà chúng ta mong muốn. Tuy nhiên là càng làm nhiều thì lại càng thấy rằng cái việc chúng ta nên siêu âm trước, và chúng ta cũng đã có tiên đoán trước được cái biến thể của cái hệ động mạch nó như thế nào rồi, thì điều đó giúp ích rất nhiều cho cái quá trình mà chúng ta sẽ thao tác sau đó. Đó là cái kinh nghiệm cá nhân của tôi. Và hiện nay tại khoa da liễu thẩm mỹ da cũng đã triển khai cái siêu âm cầm tay. Chúng tôi cũng sẽ tiến hành thêm một số cái nghiên cứu khác để sẽ có công bố hệ động mạch, từng cái nhóm động mạch trên người Việt Nam. Một lần nữa lại rất cảm ơn bà báo cáo viên chiều nay. Nghĩ rằng là sẽ buồn ngủ nhưng mà không ngờ là không hề buồn ngủ, cứ bị cuốn hút liên tục. Và trong hội trường của chúng ta không biết là quý đồng nghiệp có đặt những câu hỏi gì hay không ạ? Hay có thêm phần tham luận gì hay không ạ?
Lần đầu tiên em xin gửi lời chào đến cô Lê Thảo Anh và các báo cáo viên người Hàn. Cảm ơn nhà hàng đã tổ chức một cái buổi hội nghị rất là chất lượng. Và em sẽ có một cái câu hỏi muốn hỏi cho các báo cáo viên người Hàn là I have a question for the Korean doctor. How can we determine exactly the smart layer when we do the thread clip between the young customer and our customer? You know, our customer, they have a smart layer, soft and thinner, and maybe we go through and deeply to the deeper layer. How can we determine exact the smart layer for, and then we get the best procedure?
Can you repeat that again? What are you saying about smart layer?
My question about the smart layer. How can we determine the smart layer exactly?
I mean smart layer, safe layer, smart layer.